All right. Good morning, good afternoon. It's Dr. Robbie Wyatt, Chief Clinical Officer with Ergo-Flex Technologies, home of the Neon Trac, which we're doing our first ever webinar, Neon Trac training today. I appreciate everybody that's here. Dr. Daniel Larson, good day, sir. David Secker, sir. Michael Clancy, Dennis Bartek. Oh, let's see who else we got on. Dr. Moore, Alan Cross, David Popkin, woohoo! Awesome, 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 guys. If you open up your chat area, if you have, let's see, I don't believe anybody I see so far actually has a camera or a microphone, but if you do, it can always, and you had a question, just let me in. We got Dr. Applebaum and we have Dr. Ryan coming on board. Hey guys, can everybody hear me? Shoot me a message in the right corner so I know if you're there and you can actually hear me. Woohoo, Dr. Cross, good day, sir, good day. Dr. Moore, awesome, appreciate it. Okay guys, I tell you what other questions you have, put them into this right side and we'd be in good shape. So I can start off. Does anybody just have their Neon Trac and has not gotten into the online resource center? If you have not, reach out and I will have Elizabeth actually get you on there, okay? Because everything that we're gonna be talking about that today is gonna be pretty much available there. So if you have any questions, just let me know, okay? So, the biggest thing, and one of the big things that we've been seeing here recently, make sure I'm getting everybody's, is, sorry, I'm doing a little housekeeping. Who else we got? The biggest thing problem that we have with docs calling us up and saying there's something wrong is actually with the strap that goes around the tibial plateau and the pump. That pump tends to, it's directly out of a blood pressure cuff. So it's got a metered release on it. So if that's not being completely opened up when you release pressure on the patient each and every time that you're treating a patient on it, and there's air left over in that bladder, then the next time you put the patient on there, you're actually going to have to pump it up more to get the same amount of grip. Okay, so please, 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 please release all of the air, even if you have to smash it out. Because the more times you pump it up each successive time, it means that the more problems you actually have with it. And that bladder can actually bust. It can pop. There's two nipples on the bag itself. They can pop off. One goes the hose on there, one has a little cap. So if those are leaking, you can check those very specifically. So we got a few more docs coming on. Woohoo! We are getting full. I like it. So that's one of the critical aspects of the Neon Trac, is making sure that you can actually release all the air out of the bladder, okay? Each and every time. Again, it is a metered release because that is a blood pressure cuff bladder. So when you take pressure, just like when you take it up to high pressure and you're trying to read pulse when it turns back on and turns back off, it is very, very important that you release all of that air, because if you put a patient on it next time, the tibial plateau strap is not going to entrap very well, okay? It's gonna have too much cushion in it, and then when you lay it on, all right, now you've already got maybe 6 or 8 pumps of air in it. Now you got to put another 12 in it, and it expands. That's how docs end up blowing that bladder up, okay? And just a word of caution, we didn't manufacture that bladder. It's not really on us. That's an error on user error. So we typically do not cover that under your warranty. So we do take into account that. Dr. Hancock, good day, sir. Dr. Erickson, Woohoo. All right, so we've taken into account if you have a warranty, what JT is looking at it case per case. Basically, if you have the warranty, we'll ship you out the first one, and if it continues to happen, it's really more of a training issue, and then that one's on you. They're not exactly cheap. So again, make sure that you release the air each and every time out of that bladder. That's actually what gets us the distraction. Anybody have any questions? I see everybody that's in. Dr. Moore, awesome. Dranko, Dr. Gill, Dr. Clancy, Applebaum. We have Liz keeping it real. We have Dr. Erickson twice. Awesome. You must have somebody with you. Hancock, Bartek, Popkin, Besecker, Larson, Utacker, Cross. Awesome. I appreciate you all being on. Hey, y'all don't forget about our Chiropractic Instruments of Success show. We do it Tuesdays at 1 p.m. every Tuesday on our Facebook live show, Ergo-Flex Technologies page. Lots of great information. I just interviewed Dr. Jennifer Rosenhart yesterday from Closer Chiro. I know Dr. Larson's heading up there next weekend, and he's going to get some fantastic training. I'm really excited about that. So if you have any questions, please let me know. I will see them hopefully. If you have a question you want to, and you have a microphone, then I'm happy to, but I don't see anybody that does. I'm happy to open you up and have a question. So first question I got so far, Dr. Larson's, what's the typical treatment plan for the knee on Trac? I'm going to suggest that, so if we're talking about, if we're doing straight osteoarthritis or we have a sprain strain or a meniscus tear, it's pretty much going to take whatever we need. So I'm sorry, I'm getting sideways on this. So I'm reading messages and trying to talk at the same time, not my forte. Typical treatment plans for a knee on Trac. So let's say a case would be somebody that's got mild to moderate degenerative joint space loss. Let's say they got 50% space loss in the medial compartment. They've got an MRI, you take x-rays, recent x-ray shows that that joint space loss is 50%. They got maybe mild degenerative bony changes. What do you need to do? As long as you don't have overtly loose ligaments and a really sloppy joint, I'm going to recommend 3 times a week for 8 weeks, a total of 24 visits. I do recommend a pre-x-ray, and I definitely recommend that you do a post x-ray. Now, I don't recommend a post x-ray at 2 months. I recommend a post x-ray at 6 months because it's going to take the body that long to really start to regenerate that joint space, which is absolutely critical. Okay, so 3 times a week for 8 weeks. That is going to be pretty much your standard protocol. Protocol 3, which is intermittent axial distraction only, which is what the knee on Trac does. But I like that one because it distracts. Say you set it up for 15 pounds, it's going to hold 15 pounds for 60 seconds, and then it's going to back it off about 25% of the 15 pounds, hold that for 30 seconds, and then 60 seconds, and then 30 seconds, and 60 seconds. So 3 times a week for 8 weeks. I recommend a reevaluation on what they need to have every 4 visits. In other words, if I'm going to add 1 pound every 4 visits, I need to be doing a small evaluation on that. Now, I did re-exams every 8 visits. So I do a re-eval every 4th visit, re-exam every 8th visit, then I can take them on. I'm going to progress them through more and more and more. All right. Let's see. Dr. Applebaum, can the knee on Trac be used on a patient with lateral subluxation of the tibia with respect to the femur and lateral patellar subluxation? Patient has severe bone-on-bone contact. I'm going to be really cautious with that one, Dr. Applebaum, especially if they have significant joint space loss. I would do a trial treatment with them, and I'd use protocol 4 or 5. Because I want intermittent axial distraction. And excuse me, not intermittent axial, I want gradient or gradual. So I want you to take them and gently move them out over time, okay? Now, if they've got a really sloppy joint, it's not gonna be doing us a whole lot of good to be trying to stimulate that. Especially, that's really, I mean, that's, if you have that's a big one, okay? So lateral subluxation of the tibia with respect to the femur, lateral patellar subluxation. And I would only do it if they get immediate joint pain relief. Pretty simple. I wouldn't want to get too much more into that. So you could definitely use it on a patient like that as long as they're responding positively. If they are not responding positively, you need to take them out as quick as possible, okay? It's really tough with the ones that that actually have that lateral subluxation. It's really hard for them. Hey, Dr. Popkin. We just had Dr. Donnie just jumped in. Thank you, sir. Appreciate you. Keep me straight. JT's on board. He wants to hear everything. JT, I did go over the bladder. What else we got? Man, we got a bunch of people. I'm happy. So send your questions in the chat. Actually, send me a question. We got 2 questions up. Typical treatment plan so far is 24 visits 3 times a week for 8 weeks. Now, I do want to revise that a little bit. So when I was doing regenerative medicine, so we were doing stem cell injections. The nice thing is that they don't quite need as much. They need the same amount of time, but they don't need as many. So I did 1 time a week for 8 weeks. So the knee on track is a perfect platform to take you into the regenerative medicine if that's where you want to go. It is an absolute beautiful platform to get into knee pain niche because you have knee pain patients in your practice right now. They're just not telling you it's knee pain. They're telling you sciatica or something along those lines. If you're treating back pains, if you're treating patients with back pain, you have patients with knee problems and significant degenerative problems. So as part of my protocol, especially after I got the knee on track, and I was talking to Dr. Rosenhart yesterday, and she's like, boy, knees are just not my favorite thing. And I feel their pain because I remember when they were not my favorite thing either, all right? They walk in and I'm like, I don't want to deal with your knee, so on and so forth. The knee is an absolute home run when it comes to that. It'll become your favorite thing because it's such a great cross-referral system. So definitely get into the knee on tracks. It's such a powerful tool for your clinic because you got patients in there with knee problems. Oh, getting back to what I was doing for somebody that came in with back pain, I immediately asked, how much knee pain are you having? How hard is it for you to get up and walk? And definitely I watched them actually walk. I walked them from my waiting area to the exam room, which was a good 50 steps. In doing that, you can see exactly what their gait is. And then that lets me know, hey, how much knee pain are you having? Oh, my knee pain has been killing me for years and years and years. Mr. Smith, if it's okay with you, I'd like to take an x-ray and just check out your knees and make sure we don't have any hidden problems there. Sure, doc, no problem. Or, no, I just want you to focus on my low back. You got to ask permission to be able to go into those other areas if you don't have a good orthopedic reason why. So you got a low back pain patient that's coming in, you're treating them on the back on track. Now you have the opportunity to fix their knee. If you're going to do a bilateral AP knee standing, shoot that. And if they got significant joint space loss, or they got orthopedic findings or neurological findings, now you can go to the patient and say, hey, look, I know you came in for back problems, but we need to fix your knee as well, because if we don't fix your knee, you can't fix your back totally, okay? So Dr. Popkin, if charging patient per visit, what is the typical charge per visit or per 24 visits? So I'm recommending the docs charge anywhere from $55 to $100 a visit. All right. Now, what I personally did was it was $55 per visit per knee. We were all cash practice, and that was if you paid per visit. Right. Typical 24 visit knee protocol for a patient was about $4,000. They got an adjustment. They got myofascial release or something like Trigenics. Typically 8 visits of laser, and that was a 24 visit protocol. All right. Oh, they got active care as well. So we did a 15 to 20 minute session 3 times a week for 4 weeks. I typically got 12 visits of that. So that was a $4,000 program, 1 knee. That didn't include the back. All right. So I did $55 per visit per session. Okay. If they had 2 knees and they treated both knees, I gave them a break. I gave them half the cost of the first knee. All right. So it was like $82.50. $55 for the first knee. If they did both knees, $82.50 for that entire session. Typically a 12-minute protocol. They're sitting there on the chair. I don't have to completely reposition somebody, so I gave them a break. I gave them 50% off the second one. Dr. Hutaker, same thing, pricing average per visit. I've got docs that have it upwards of $100 per knee per visit, okay? I've got docs that have it down to 35. I do not recommend less than 50. It's just such a, it's such a powerful. So Dr. Applebaum, how much time are you spending on knee traction per session? Do you increase time and poundage in certain intervals? I always left mine at 6 minutes. And the main reason why is because we are joint specific with the knee, all right? We're not moving the ankle or not moving the hip. If we are, it's a minuscule amount. So you are pulling specifically on the knee joint itself. There's a lot less tissue slack that we have to go through than say we're working on neck or low back, especially low back. About 70% of your time in a low back is all about getting the tissue slack removed, okay? Very, very important. Once you get that tissue slack removed, now you can get into a decompressed state for longer periods of time, okay? With the knee, you're there within 35 seconds, okay? 30 to 45 seconds, you're where you need to be with getting that. And you only gotta move that joint about 5 millimeters, guys, not that much, 1/8 of an inch. So I didn't typically increase time, I increased poundage. So every 4 visits, I would increase 1 pound, all right? And my ceiling for most patients that were not 300 pounds or more was 20 pounds. Did not go much past that, all right? So every 4 visits, I did reevaluation. Give you a little background on how I did for patients. If a patient weighed 175 pounds or less and we're not a high impact athlete, tennis, runner, CrossFit, I started them at 12 pounds and added a pound every 4 visits. If they were 175 pounds heavier or a high impact athlete, I started them at 15 pounds. Every 4 visits, I reevaluated. Clinical necessity to actually increase poundage. And my cap was typically 20 pounds. Somebody over 300, 350 pound class, I would add them, I would take them up to 25 pounds or a little bit higher, but because of all the tissue slack that you have to go through, okay? But I monitored those patients very, very closely. 20 pounds is a tremendous amount. And hey, let me give you this. If you put somebody on the knee on track that doesn't have a knee problem, they don't feel like it's doing anything. I put it on my left knee and it doesn't feel like it's doing anything. I put it on my right foot, I know exactly. So I've had that a lot. Docs coming at me and go, man, I don't feel like this thing's doing anything. And then all of a sudden they put a 110-pound lady on there for 15 minutes at 25 pounds. She gets off, it feels great. Next day she can't walk. She's cussing them. It's pretty bad. So I recommend staying at 20 pounds or less and moving them up appropriately. Dr. Clancy, I have a patient who had minimal results with stem cells about a year ago. He has had medial compartment loss and has loss of extension. His knees don't lie flat on the table. Oh, looking for any other ancillary helpful procedures you suggest. Besides the knee on track, so one of the key mechanisms for the knee on track is actually resetting full extension, the screw home mechanism. All right, that's what's happened with this patient. He's lost that full extension, that screw home mechanism, which means that his popliteus is probably like a cord of steel and very, very tender behind the knee. The gastroc actually helps completely extend the knee. I would start looking at metabolic factors for that patient as to why he didn't respond to stem cell, right? I have a very clear recollection of a patient that we had that went through a back pain and sciatica program, 24 visits, did fantastic, cleared up his sciatica, cleared up his low back pain, no problems. And then he drops almost $10,000 with us for bilateral knee stem cells. We got him about 4 weeks in. He was doing once a week with the knee on track. We continued his back on track for that, and he wasn't responding. Come to find out, he's a 2-pack-a-day smoker, all right? So the second I found that out, I stopped his program. I said, we're going to get you off these cigarettes. Took him over to the nurse practitioner, prescribed him Chantix. Within 2 weeks, he was down to a 1/2 pack a day. That's when he actually started responding. So for those patients that don't respond, unless they are just severe degeneration, there's a reason why they're not responding, okay, to the stem cell. It could be the stem cell's junk. Okay, what kind of stem cell did they have? Fat-based? Did they have PRP? And somebody called it. There's a lot of different factors there that could happen, but typically it's a metabolic issue. If they are rampant, out of control, make sure I got everybody in here. If they're rampant, out of control diabetic, they are not going to respond well. Okay, so very, very important that you clear all their metabolics, that you make sure they're not heavy smokers, they're not deficient in something like vitamin C or something along those lines. Key component. So, so I would definitely, the key for that patient, this one that Dr. Clancy, that the medial compartment loss. So you started him at 25 pounds. Since I didn't know better, if I can get his legs flat in the prone position, I will be happy. No better ball. So in that case, when somebody's, I would continue. I mean, if he's doing well at 25 pounds, I'd keep him there. Okay. But there's a reason why he can't extend. So neurologically, you're going to have to take a look at what's happening with the quad and the hamstring. All right. You need to look at the pes anserine. Is pes anserine very, very tender? All right. Semimembranosus, tendinosus. Are those in fight? So you got to take a look at both his strength and lengthening around that knee. If you know trigenics, you definitely need to put trigenics on him, but I can pretty much bet you the reason why he's not going into full extension is directly related to the popliteus. You're going to have to take a look at the popliteus, the way the gastroc is actually working, the way the hamstring, these hamstrings are probably super, super tight. You need to strengthen and lengthen both of those, and then you should be in better shape. Yeah, you've been doing a PETA A, which strengthens popliteus, right? So I don't think you got a problem with strengthening the popliteus. You probably have a problem with lengthening it, because when you can't get somebody into full extension, that popliteus is it's firing off. It's trying to pull them into full extension. So if you actually release it, now it's going to pull them in. Okay. Any other question, guys? Boy, we got a lot of people on board today. Let me know, is anybody having any trouble with getting patients set up and how they actually get them on and off? That's one of the critical factors is patient flow. What I found is typically the doctor is excellently trained, but staff members maybe they just take 2 degrees and they're off here just a little bit and they're not doing the same thing over and over and over again, or they find a better way to do it, and the doctor doesn't know that. Maybe it's changing different things. Definitely, I recommend that you're training on all of your equipment, not just on the Neon Trac, especially with your CAs, that you're training with them on a regular basis, so that not only if they found a better way to do it, great, but if they've just gotten a little bit lax in how they do this or how they do that, especially releasing that bladder all the way, then sometimes we can actually start to really have some problems. Any other questions, guys? And Dr. Clancy, I appreciate that. Awesome question. Keep going. Knee pain function questionnaire test. Doctor. Okay. Boy, you got me on that. It's we used, dadgummit, Doc, I will get you that information. I want to say it's the Chicago West, but it's not the Chicago West. We did that with our stem cell injections. We actually did that with them prior to the injection, and then we did it a week later, and then we did it at the end of the 8 weeks. It's actually a great questionnaire, because a lot of times patients actually forget how much better they're doing. And so at the end of the 8 weeks, they go, well, Doc, I'm still hurting really bad. And you go, well, okay, let's take a look at this. And you go, the questionnaire they just filled out is like 90% better than the questionnaire that they just filled out. So I will get you that specific one on what that is. Now I've got Sims-Weinstein in my head. It's not the right one. Okay. So Dr. Hopkins, so Jared, is there a CPT code for knee traction. Okay, so here's what's great about the knee on Trac. All right, it is FDA registered as a powered exercise equipment. Right, it is not registered as traction. Technically, there is no knee traction code. So we start looking at different codes that apply, because this is a billable service. I recommend it be a cash service, but if you're getting good results with insurance, then by all means continue to use it. We did bill it for our personal injury cases, our car accident patients, the knee, dashboard knee. I build it under 97112, neuromuscular reeducation. That's how I personally build it. Other ones, 97110 is an appropriate code, probably the most appropriate code. Actually, I would say that 97112 is the most appropriate code. Neuromuscular reeducation, because you're entrapping the insertion points for the quad, for the hamstrings, for the gastroc. So you do get neuromuscular reeducation. Now, as always, you need to make sure that you're getting up in time for the correct. So you're going to have to go up to 8 minutes in order to make those codes happy. Now, you can do 6 minutes if you got a minute setup time and a minute takeoff time, which that's up to you. The other ones, say you're already using those codes and you're not interested, you just want to document, I recommend 97139, okay? Unlisted therapeutic modality. So 97110, therapeutic exercises, 97112, neuromuscular reeducation, and then 97139, therapeutic modalities. This list and everything is actually on the online resource center. So if you need access to that and you have our equipment, then just send Elizabeth at backontrac.com. Trac has no K, and she will get you on board if you're not on there. So let's see, is there, Dr. Jared, Dr. Problem, will insurance cover the knee traction? If so, what physical therapy goes? We just went over that. Appreciate the question, guys. Any other questions? Any other case studies? Anything else that y'all can think of that we need to cover? We're quickly running out of time. But speaking about it, so if you've got a car accident case, you got a dashboard knee, one of the big problems with that is that, you know, the ACL or the PCL usually both gets really torn up in that factor. So, and you lose the screw home mechanism. Again, you lose because they're getting forced into flexion. So you really have a tough time with those cases a lot of times. Now, the other thing is that when you lose that joint space loss, that joint space, like Dr. Clancy and Dr. Applebaum, when you lose those spaces, you begin to, the ligaments actually fold, okay? They fold over. When they fold over, and they're in there for more than 2 weeks, they actually scar in that new position, right? So there's nothing that we do either as a chiropractor, through trigenics, myofascial, ART, or through our manual hands-on stuff that actually helps unfold that ligament. That's why the knee on Trac is so, so, so important. Jared, what are some knee conditions that may be contraindicated? So tibial toe fractures, okay? Whether they're 6 months old or years old, those tend to bode they don't respond very well, okay? No active cancers, guys. Uncontrolled diabetes. Don't want to take on those. You got to get those people under control, okay? They just, metabolically, they're not stable enough to do what you're asking them to do. They don't even respond well to getting, physical therapy or adjustments. So you got to make sure that and then specifically no active infections, viral, bacterial, or fungus, okay, especially for total knee replacements. This is an amazing, amazing treatment plan for patients that have total knee replacements, okay? The criteria is that they have to be at least a year old and no signs of infection, bacterial, fungal, or viral, okay? Because the bone, the hardware actually harbors those infectious disease processes between the bone and the hardware. So it actually starts to erode away at how it's actually working. So you got to get those patients cleared of any type of infection. Now, if you have a surgical approval they're 3 months post surgery and the surgeon says, yeah, you can do what you want, this is perfect, go forward with them, because you still have to do the things you have to do on a normal joint. Okay, you have to reset the mechanism, you have to rebuild the joint space, you have to unfold the ligaments, ACL, PCL, in a normal one. And a total knee replacement, you can only going to be working on lateral, collateral, and medial collateral. So contraindications are basically infection, tibial toe fractures that are displaced, like Dr. Applebaum asked earlier, a true subluxation where they're moving back and forth, and just it's just an absolute bone on bone. Now, if you do the bone on bone and then you add a stem cell, you're probably going to get great results. If you're trying to work on somebody that's truly bone on bone and you don't have the luxury of a stem cell or a PRP, you're probably going to have to work on that person 6, 8, 9 months before you start to really see a big difference. Typical initial exam for average patients. So I'm going to check anterior and posterior drawer. I want to see the ligament. I want to see if the ligaments are intact for medial and lateral collateral. And then I want to do something like McMurray's, where I want to see if they have a pinch or a catch for any type of meniscus. We just want to be able to to clear. You don't want a complex tear or even a simple tear that's not very old, because what happens with those is, as you distract the joint, you can actually float the edge of that tear. That tear is actually what's painful, is those edges coming back on top of one another. So if you do that, you lay somebody back on, boy, that's painful, and the knee locks, that's it, they end up in surgery. Typical initial exams, so on and so forth. So, one of the things I did in my clinic was we stacked therapies, okay? So I took advantage of the time, that 6 minutes that they were on the knee on track. I put a laser on them. We had a laser. I just put the laser on them while they're doing it. I've got docs that are actually putting, the Anodyne. The Anodyne has a knee sleeve. Heck, the Rebuilder has a knee sleeve. So they stack those modalities so that they save some time, okay? Now, you have to be cognizant that I was a cash practice, so I don't recommend stacking modalities and billing insurance, because that's a no-no, okay? And then, Dr. Larson, how often would you do a follow-up treatment or treatment plan after an initial 24-visit care plan? Build those into wellness. It depended. Most everybody in my clinics got a treatment plan up to 6 months. So they got 24 visits over 8 weeks, and then I would see them once a week or once every 2 weeks for the next 4 months. I might see them once a week for 2 months, and then back them off to once every 2 weeks for the next 2 months after that. But I typically took everybody else, if their schedule would handle it. I had patients going all over the world. They go. And one guy that he was a ship inspector, so he came in. He'd be in for 5 days. Guess what? We treated him for 5 days in a row, and then he'd be off for a month and then come back. So definitely recommend, especially anything past a moderate joint space loss or significant ligament laxity. They're going to need some extra help to get to that 6 month mark. Once you're to the 6 month mark, at least 75% of the healing process is going to be in place. You actually get that taken care of. So, Dr. Propkins, how long after acute injury do you have to wait to start a knee on track? So I want them into subacute, okay? If it's a simple sprain strain, do all your other magical stuff too first, right? Start adjusting them, doing all the things you need to the spine to make sure. I typically want them into subacute. So if you've got a simple sprain strain, I'm going to be starting them on the knee on track probably in the 3rd to 4th week, okay? If you got somebody that's got a simple meniscus tear, I want that tear to have a good 3 months to start to heal up before we start unloading it. Again, that goes back to floating the edge. I do not want to float an edge. If you float an edge, you're just asking for a lock knee. Somebody's got a complex tear, bucket handle tear with multiple, so on and so forth. I'm going to wait probably 6 months before I put them under distraction. I need all of the fibers to start laying down those fibers, even if they're disoriented, before I float an edge. That was my protocol. I didn't like doing much more past that. Okay. How long after acute? Yep. So what else? Any other questions, guys? Y'all doing awesome. I appreciate y'all coming on board today. Anything else? We're right at the 35-minute mark. I tell you what, next week I'm going to have Dr. Vitanzi on our Chiropractic Instruments of Success show, and he does gravitational positional alignment. It's an absolutely amazing adjusting technique that I've actually been getting done to me by a friend of mine, and I've had some amazing results. So tune in for Dr. Vitanzi next Tuesday at 1. Next Wednesday at 1, we're going to do the Back on Track training seminar. Very similar to this. Ask me questions. I'll go over everything that we need to, and we'll move on from there. Does anybody have any, has anybody been able to get, what am I trying to ask? Has anybody had trouble getting on the online resource center? Last week, we stacked a bunch of new videos in there specific to the knee on track and the back on track with a lot of new documentation. So a lot of your questions that you have, there's written document material in there specific to those. So absolutely go on there. All right, guys. Any other questions? Shoot me one real quick. If you have any troubles actually getting your equipment to work right, I do highly, highly, highly recommend that you not unplug, but turn your knee on track off during non-clinic hours, okay? I highly recommend that you actually have it on a battery backup or surge protector because if you have an electric storm come through, it can knock out that motherboard and then you get a dead unit, and that is unfortunate. We do not want to see it. All right, guys, join me next week for our Back on Track webinar, and absolutely ask me any questions you need during the week. I'm happy to hop on a phone call. If you need a specific video, I can usually crank one of those out pretty quick. We are working on some marketing ideas to get you some better foundational, but that's coming. And then if anybody's going to be at Chiro Texpo next weekend in Dallas, come by and visit us. I'm sure we're going to have some great show specials, and I'll be doing some equipment training there, and you can pick my brain all you need. All right, guys, I appreciate it. Y'all do a wonderful job. Keep saving lives and keep taking care of those patients.